So we keep on with the program, and now we have the privilege of having with us Saskia Boss, and she is a reference in the lung complications after allogenic transplantation. And as all of you are aware of that, these are for sure the most scared complications after transplantation, with a very difficult diagnosis and even more difficult treatment. So it is a great opportunity for us to learn from Saskia, and now she is at the Transplant Pulmonologist University Hospital in Leuven. Welcome to Sevilla, and thank you for being here with us today.
Yes, so thank you very much for the kind invitation to be here today, and also congratulations, of course, with the very nice program that you have built here. So I was asked to say something about pulmonary complications. Well, that is, of course, quite a broad topic. Do I have to lower it a bit? Yes. That is, of course, quite a broad topic. So I will mainly focus on pulmonary GvHD because that is also just my area of expertise. And is it not moving? Yes, now it is. Okay. So I have no specific conflicts of interest related to this talk. This is going very well. Yes. So pulmonary complications, well, you all know that different complications are possible, and you all have, I think, even more experience than me with especially the infectious complications and all the complications that you see very early after stem cell transplantation. And so I will mainly focus on pulmonary GvHD. And so we have seen a shift over the last couple of years from early to more late complications. And this is mainly because of better prevention and better treatment of, for example, infections. And so the late onset non-infectious pulmonary complications have become very important. And they occur in about 20% of our patients, and they significantly contribute to morbidity and mortality. And this has also been recognized by the community that prevention and treatment of these pulmonary GvHD and late onset pulmonary complications are a significant unmet need in our community. And so I will mainly focus on the pulmonary GvHD phenotypes and then also the importance of why we have to diagnose our patients as early as possible. And then finally, I will say something about the management of pulmonary GvHD based on our guideline. But first of all, I would like to show you two cases. The first case is a 28-year-old man. And at the age of 18, he was diagnosed with Hodgkin lymphoma. He was treated with chemotherapy. But unfortunately, the disease came back and it was quite difficult to treat this patient. And in the end, at the age of 20, he received an allogeneic stem cell transplant. And here you see his lung function evolution. So you see it at the time of diagnosis, you see it at the time of transplantation. He did have some acute GvHD. He also had some chronic GvHD of the skin and of the mouth, quite a typical clinical scenario. And then he was diagnosed with pulmonary GvHD. And you also see the CT scans at that time. And so the top CT scan also shows some sequelae of the radiotherapy that he received, but he had also some other abnormalities of the airways with some bronchiectasis. And you see that there was a persistent, severe decline in lung function. And in the end, this patient did receive a lung transplant. Unfortunately, a couple of years after his lung transplant, he did develop chronic rejection after lung transplantation, what we call CLAD, or chronic lung allograft dysfunction. And this person received a second lung transplantation a couple of years later. And I'm very happy to say that this person is still doing very well at the moment. I also have a second case. This person, he developed AML when he was a kid, when he was still very young. With recurrence of the disease when he was 12 years old, he also received a stem cell transplant at that time. And then at the age of 17, he developed pulmonary GvHD. However, this was a different clinical presentation, and you can see on the CT scans that there are a lot of abnormalities with mainly fibrotic remodeling of the lungs, and so this was a restrictive phenotype of pulmonary GvHD. And that also brings me to the pulmonary GvHD phenotypes. So nowadays, we do know that there are actually two main clinical phenotypes of pulmonary GvHD. On the one hand, we have bronchiolitis obliterans syndrome, which is characterized by inflammation and fibrosis of the airways. But we also have a less common phenotype, restrictive pulmonary GvHD, and this is characterized by inflammation and fibrosis of the lung parenchyma. What is very interesting is that we also have bronchiolitis obliterans syndrome after lung transplantation, and this is actually identical to BOS after stem cell transplantation. And the same is also true for the restrictive phenotype. So we know the restrictive phenotype, restrictive allograft syndrome already for a longer time after lung transplantation, but restrictive pulmonary GvHD also resembles restrictive allograft syndrome. So I think we can learn a lot from each other. But we also know there are a lot of similarities between these diseases and also a lot of risk factors that are the same. For example, respiratory infections, reflux, acute rejection, or acute GvHD can contribute to the onset of chronic lung rejection. Of course, there are also some disease-specific risk factors, like, for example, conditioning regimens used in the stem cell patients. But it is postulated that injury of the small airways and or the lung parenchyma induces an uncontrolled inflammatory reaction. And this inflammatory reaction is mainly driven by alloreactive T and B cells, but now we know that other immune cells, like for example the neutrophils, as also highlighted earlier this morning, eosinophils, NK cells, etc., are involved. And so in the end, an aberrant repair response can occur and can result in lung fibrosis. And so in the end, tissue inflammation and fibrosis can result in permanent organ dysfunction. And when we look at these clinical phenotypes, so bronchiolitis obliterans syndrome is at the moment the only entity that is officially recognized as a pulmonary GvHD phenotype. It usually occurs quite early after stem cell transplantation, within the first 2 years, but we can also see it many years later, so we always have to think about it. Usually in combination with chronic GvHD in other organs. And they say about 5 to 40% of our patients, but we actually don't really know how often it develops. It is most likely underestimated the prevalence because in the study where you looked at patients with chronic GvHD, they actually saw that more than 50% of the patients with moderate to severe chronic GvHD also had lung involvement. Then if we look at the restrictive pulmonary GvHD phenotype, well, it is not officially recognized yet as an entity of pulmonary GvHD, even though it also occurs with chronic GvHD in other organs. And so we don't really know how often it develops, and it is very difficult at the moment to diagnose these patients. And so that also brings me to the diagnosis of pulmonary GvHD. So here again, you see a typical presentation, clinical presentation of pulmonary GvHD, where you have a significant drop in the lung function with a, severe persistent drop in lung function. And so for the diagnosis of bronchiolitis obliterans syndrome, you have an obstructive lung function decline, and so a decline in forced expiratory volume in 1 second, the amount of air that you can blow out in 1 second. Chest CT can be normal, but you can also have abnormal findings, like, for example, air trapping or bronchial wall abnormalities, like, for example, bronchial wall thickening and bronchiectasis. To make the diagnosis, there needs to be a decline in FEV1 below 75% of predicted, with a persistent decline of more than 10% over the last 2 years, and also in combination with signs of air trapping, either on lung function or on the chest CT scan, or in combination with chronic GvHD in other organs. And then for the severity, we use the general NIH scoring system that you can see there. But there are some comments that we have to make when we use these current criteria. And first of all, that is the need that we only look at the absolute FEV1 value. It makes more sense, like we also do after lung transplantation, to look at the evolution of FEV1, the FEV1 trajectory, because we all have these patients that are quite young at the time of stem cell transplantation. They do, for example, have an FEV1 of 90% at the time of transplantation, and then they drop to, for example, 79%, and we all have the feeling that something is going on in this patient. Patient has lost 11% in FEV1, but does it fulfill these criteria yet? And the same is also true that you need to have an obstructive lung function with a Tiffinol index below zero point 0.7. This is something that we usually only see later when the disease is already more advanced, because bronchiolitis obliterans syndrome is mainly a small airway disease, and so you miss the early stages of the disease. And this has also been shown that it is very important to diagnose the patients as soon as possible, because the lower the FEV1 is at the time of diagnosis, the poorer the outcome is. And this seems very logical because you miss that first window of opportunity where treatment might be more effective, where some of the inflammation and fibrosis might still be reversible. Although, of course, we also have to acknowledge that even lung function is not ideal, because by the time that the lung function starts to decline, there is often already a certain amount of irreversible damage. And this has also been acknowledged by the NIH, and they have updated their recommendations a couple of years ago. And so what they recommend is that we perform a full assessment with a full lung function and a chest CT scan at the time of stem cell transplantation, just so that we have something that we can compare to, that we can refer to. And then to stimulate early diagnosis, they recommend doing routine systematic screening in all our patients, so also our asymptomatic patients, ideally by doing spirometry every 3 months during the first year, then yearly thereafter, but also at the time of chronic GvHD diagnosis and at 3 months intervals. But of course, ideally, we would like to have better biomarkers so that we can detect these patients before the lung function starts to decline, and that we can also predict who are the patients that are at risk of developing pulmonary GvHD. And a lot of centers are looking into this, but at the moment, we unfortunately do not have a good biomarker yet. So what about the other clinical phenotype, the restrictive pulmonary GvHD phenotype? Well, this is associated with a restrictive lung function decline, so a concomitant decline in both the forced expiratory volume in 1 second, but also the total lung capacity. And in combination with abnormalities on the chest CT, for example, ground glass opacities, but also consolidation. And you can also have severe fibrotic remodeling, like you see on the right side, that is called pleuroparenchymal fibroelastosis, where you have, severe fibrotic remodeling of the lung and shrinking of the lungs. But like I said, unfortunately, we do not have an official definition yet. So we also do not have official criteria to diagnose these patients. That makes it very difficult to detect these patients, even though we know that it is very important to make a difference between these phenotypes. It is important to accurately phenotype your patient, because patients with an obstructive phenotype do have a better outcome than patients with a restrictive phenotype. And so it can have an impact on the prognosis of your patient, but maybe also on the treatment options that you use for your patients. And so that also brings me to the last part of my presentation, and that is the treatment of pulmonary GvHD. And so we all know that despite the drugs that we do have available, that it is still very difficult to prevent and to treat patients with chronic GvHD. There are not that many standardized approaches, and also when your patient does have chronic GvHD, we do not have that many options available. And this is also something that we acknowledged, as so it was a joint effort between the EBMT and also the European Respiratory Society that we created this guideline on the treatment of pulmonary GvHD. And so what we wanted to do is we acknowledge that it is difficult to treat these patients with pulmonary GvHD, that there are no standardized approaches available. And so we wanted to create evidence-based recommendations, and we mainly focused on adults, and we mainly focused on pulmonary GvHD patients with the BOS phenotype, because this is the most common one, but also the only officially recognized one. And for this guideline, we used the GRADE approach. So first of all, we of course formulated the PICO questions and also the narrative questions that we were interested in. We selected the outcomes of interest. A literature search was performed and the articles were screened. And of the included studies, the data was extracted. We created evidence profiles and then we came to a conclusion and we created the recommendations. And so here you can see the PICO questions that were included in our guideline. So the standard sentence that we used was in adults with lung GvHD phenotype BOS, should drug X be used in addition to their conventional immunosuppressive regimen? And we looked at inhalation therapy, we looked at the typical FEM therapy, we looked at TKIs, imatinib, ibrutinib. We also looked at the more novel drugs, ruxolitinib, belumosudil, ECP, and then finally, whether in adults with end-stage pulmonary GvHD, whether lung transplantation should be performed. In addition, we also had two narrative questions. Well, first of all, how and how often should we re-evaluate our patients? How often should lung function be performed? And also whether we should pay attention to additional treatment options, supportive treatment options, like, for example, up-to-date vaccinations, pulmonary rehab, long-term oxygen treatment, etc. Here you see an overview of the outcomes of interest. So in general, we looked at the lung function evolution, we looked at overall survival, quality of life, but then also the impact on oral corticosteroids, the incidence of respiratory infections, serious adverse events, and malignancy. Regarding the literature search, we did not only look at BOS-specific studies, but we also included chronic GvHD studies where BOS sub-analyses were performed. And then here you see an example of the evidence profile that we created, where we gathered all the data for a specific outcome. And then we created also these evidence to decision tables. So we did not only look at the desirable effects of a drug and the undesirable effects and the balance of those two, but we also took other factors into account. Like, for example, how feasible is it to give this drug in clinical practice? Is it available everywhere? What are the resources that we need, etc. And based on all of this, we came to the recommendation. And also for this, we use the GRADE approach where you have two types of recommendations. First of all, strong recommendations where you use the phrasing, we recommend doing this or not doing this, but also conditional recommendations where you use the phrasing, we suggest doing this or not doing this. And I can already tell you that all our recommendations were conditional recommendations. Here you see an overview of the studies that were included in our guideline, and I think this is already very important because you can see that for most of the PICO questions, we did not have that many studies. And also in these studies, quite often not that many patients were included. And so that is also already the first recommendation that we made, is that you should always consider including your patient in a clinical trial just so that we can gather more clinical data. Then in patients with established BOS, the first-line treatment consists of the typical FEM therapy. And why? Well, first of all, because for inhalation therapy, we were in favor of using inhaled corticosteroids with or without a long beta agonist, because we saw that it could stabilize or even improve the lung function, and that it was also well tolerated by the patients with a low risk of adverse events and also a low risk of respiratory infections. The same was also true for the typical FEM therapy, so we were in favor of using inhaled corticosteroids in combination with azithromycin and montelukast, again because it can lead to stabilization or improvement of the lung function. We also found that the dose of oral corticosteroids could be reduced, but there was one important side note that we did have to make, and that is it was seen in studies where they used azithromycin as a prophylactic drug immediately after the stem cell transplantation, that it was associated with a higher risk of relapse or malignancy. This was not seen in the patients with established BOS. But what if you have disease progression? Well, what are the second-line treatment options that we do have available? We did have the most evidence for the use of ECP. we were actually not that much in favor of the TKIs because of a low efficacy. And then regarding the more novel drugs, ruxolitinib and belumosudil, we would like to have more data first. So like I said, we were actually not that much in favor of the TKIs. Regarding imatinib, we were not in favor of it, but also not against it. And that was because the overall response rate was rather low. And although the risk of serious adverse events was low, a lot of patients had to discontinue their drug because of general side effects, as we also know from the general hematology population. For ibrutinib, we were actually against the general use of ibrutinib again because of a low efficacy, but also because of a high risk of adverse events, and then especially the risk of infectious and potentially fatal bacterial and fungal infections, in addition to a wide range of general side effects. So we did have the most evidence for the use of ECP. We were also in favor of using ECP because, again, it can lead to stabilization or improvement of your lung function. But in addition, we found that the overall survival was higher in the ECP group versus the control group. And it was also generally well tolerated by the patients with a low incidence of adverse events. Regarding the more novel drugs, first of all, ruxolitinib, well, we know that it is very promising in the general chronic GvHD population, but we did not have that much data yet in the BOS population. But in the studies that were available, we also saw some promising results with stabilization and improvement of the lung function, a reduction in the dose of oral corticosteroids, but we also found that there might be a risk of infection, especially in patients with a history of infections, and also specific attention should be paid to the risk of viral infections. So first, well, we would like to have more data before we can make a general recommendation for the use of this drug in our specific patient population. And the same is also true for belumosudil because here we did not actually have any BOS-specific data, so we were not in favor of it, but also not against it, just because we need to gather more data first before we can make a recommendation for this patient population. But again, we know that it is promising, and also in one of the sub-analyses, we saw some promising results in the BOS population. But what if your patient evolves to end-stage pulmonary GvHD? Well, then it is very important to check eligibility for lung transplantation. And that is because we saw that the overall long-term survival after lung transplantation was good. It was comparable to patients transplanted for other indications. And the same was also true for the complication rate. Of course, there are complications after lung transplantation. There is a risk of rejection, of infections. But again, this complication rate was similar to patients transplanted for other indications. Then in addition to BOS-specific treatment, you should also pay attention to supportive treatment options. You should check whether your patient might benefit from pulmonary rehabilitation, monitor the need for long-term oxygen treatment, and of course, make sure that your patient is up to date with their vaccinations. And then regarding the follow-up, so yes, ideally, spirometry should be performed every 3 months, and you should even consider doing this more frequently after post-diagnosis, because we all know that we sometimes have patients that evolve very quickly. Of course, also when your patient is unstable, but also when there is new onset of chronic GvHD in other organs, because this can be a sign of disease activity after an infection and after a change in therapy. But while we can all imagine that this is not always feasible, that it can be a burden not only for the patient but also for your lung function department. And so, yes, home spirometry is something that can also be considered. And so the conclusion of our guideline was that the use of inhalation therapy and a typical FEM therapy is supported in patients with pulmonary GvHD. For patients with progressive disease, ECP should be considered, and you should always check the possibility of lung transplantation for patients with end-stage pulmonary GvHD. We really look forward to having more data on ruxolitinib and belumosudil because we know it is very promising in the general chronic GvHD population, but we don't know what it does exactly for BOS. And the limitations, like I already said, we did not have that many studies, and often there were not that many BOS patients included in the studies, and there was also quite a lot of heterogeneity across the studies. And so that is also why we made some specific research recommendations. Like I already said, like we should have more studies. We should always consider including your patient in a study, also for first-line treatment options. And ideally, we would also want to look at biomarkers so that we can predict, will the patient respond to treatment, what is the risk of side effects for that patient, etc. And we also made some drug-specific recommendations. And again, I would like to highlight that we really want to have more data on ruxolitinib and belumosudil, not only regarding efficacy in this specific patient population, but especially what the safety is in this patient population. And so that also brings me to the end of my presentation. So like I've already shown, is that there is still an underestimation of pulmonary GvHD, although awareness is certainly growing over the last couple of years. I've mentioned that it is important to diagnose our patients as early as possible, and that for this routine lung function monitoring should be performed. I've also mentioned that it is important to adequately phenotype your patients, but that we do not have a definition for the restrictive phenotype yet. And like I said, that we need to have more post-specific data. And with this, I would like to end, and I really would like to acknowledge everyone who was involved in our pulmonary GvHD guideline, because it was a huge work. Without everyone's input, we would not have been able to do this. And I've also included 2 QR codes, one that brings you to the guideline, and we also have a slide deck that is a bit more easily accessible. But we are also very happy that in collaboration with the European Lung Foundation, that we created a lay version for patients. With this, I would like to thank you and happy to take any questions.
Thank you very much for this excellent presentation and for all your work. And it's time for questions and discussion. Any questions from the audience? So until we generate evidence, so what are we going to do with the patients that we are going to visit in the consultation next week? What are your preferences?
Well, it all depends also what is available, of course. So usually when I see a newly diagnosed pulmonary GvHD patient, I will start with the typical FEM therapy. And we know that some of our patients, they do respond on this and they remain stable for a certain period of time. And then when there is progressive disease, I usually go for ECP. But well, that is what we did in Newcastle when I worked there, because ECP is available. We have it on our unit available. Unfortunately, in Belgium, it is even more complicated because we do not have ECP reimbursed in Belgium. So it really makes it difficult to send patients for that treatment option. So we usually try to include patients in Belgium in a study. We were very happy that we did have ruxolitinib available. And we do have a study with belumosudil at the moment. But yeah, like you also mentioned, I show is that, yeah, we do not have that many treatment options at the moment, so it really makes it difficult.
So guess you have steroids, ruxolitinib, belumosudil, axatilimab, ibrutinib. What would be your preferences and the order if you have everything available and ready to go?
If I had everything available, difficult to say. I think at the moment I would go for ECP or ruxolitinib, just because that is my feeling that most of the patients do stabilize on this. But of course, well, both advantages and disadvantages. The infection risk is lower with the use of ECP, but then of course the patient has to come to the hospital. Sometimes they need to have a central line to be able to do it. Ruxolitinib is much easier because you can just give it to the patient, but then there's also a risk of infection. So it's all a bit about the balance and also the profile of the patient that is sitting in front of you. And then, yeah, I look forward to knowing what belumosudil will do in these patients.
Good. Would you make any difference regarding the treatment between the bronchiolitis obliterans versus the restrictive form
Yeah,
of
that's a very good
GvHD?
question indeed. So we do not know that much about it in the stem cell population yet. We do know a bit more after lung transplantation because we also have the obstructive and the restrictive phenotypes. And there we do know that patients with a restrictive phenotype tend to respond less to the treatment options than patients with the BOS phenotype. So I think we should absolutely study this further because these patients might benefit from different therapeutic options. For example, antifibrotic therapies have been tested in patients with restrictive lung rejection after lung transplantation. So this is something that they are looking at the moment, which is something that maybe restrictive pulmonary GvHD patients might benefit from too. Yeah, something that needs to be studied further.
Mm. Do you have any experience, and what do you expect about the use of antifibrotic drugs that actually the pneumologists use in this setting, for example, pirfenidone or any other
Yes.
antifibrotic agent?
So I think it is mainly pirfenidone that has been tested in this patient population. It was a couple of years ago, and it were only like case series, a very small cohort studies. They showed that some of the patients that there was a neat improvement or stabilization of the lung function. But then there was also the EPOS study, which is a bigger randomized trial. The results have not been published yet, but what I know from internal information is that it didn't seem to be effective. But again, it was in a combination of patients with both obstructive and restrictive rejection. So I think we really need to test this in the restrictive patients as C, because restrictive pulmonary GvHD or lung rejection after lung transplantation really resembles interstitial lung diseases. So it would make sense that these patients also respond to antifibrotic drugs.
Mm-hmm. There are no questions from the audience.
Well,
Yesterday,
I guess it was very clear then, huh?
It was really, and the work excellent. Actually, I have to remind you that all the presentations will be available online at the end of the meeting, so that actually you can go and check these guidelines, which are really interesting and important. Yesterday there was a comment regarding the how good is the spirometry for making the diagnosis and moreover for making the follow-up of these patients, because all of us have some cases in which actually the spirometry does not get better at all. You see that and you think that the patient should undergo lung transplantation, but then the patient is really doing better. What is your experience, and how could we actually improve the strategies, or how we can actually measure really the improvement or not of the lungs after treatment?
Yeah, that's also a very important point that you notice, is that we mainly still rely on the spirometry. It's in all respiratory diseases that we do this. It might not always be the best marker, but I do think that the FEV1 does tell you what is going on in the patient. It's maybe not that very good to diagnose your patient and to make the diagnosis as early as possible. But I think once you have a patient with established pulmonary GvHD, it is a good tool to monitor it. We also use home spirometry in our patients after lung transplantation, and we do know that there is often a difference between what they blow in the hospital when they do the spirometry there and what they have on their home spirometry. But we always say, like, make sure that you know what your value is at home so that you can compare it to that value. And it is also an easy tool to see whether if the lung function further declines, the patient can already notify you so that you can pick up further progressive disease as early as possible. But I think, yes, we also need to look at better ways to measure disease activity that is not only based on lung function, but also using biomarkers, for example. But unfortunately, not something that we have in clinical practice at the moment.
Is there any specific situation in which you would, let's say, hardly recommend to go for a biopsy, or we can skip it?
No, we don't do biopsies anymore because, well, it is always associated with a risk, of course. So when you do transbronchial biopsies, you only have a very tiny piece of tissue. And we know that the disease is very patchy, that you have areas that are unaffected and that there are areas that are affected. So it's very difficult to actually pick that white area on your biopsy. So if your biopsy is negative, it doesn't tell you anything. Of course, if you find the typical obliterative bronchiolitis lesion on your biopsy, then it does confirm that your patient does have chronic pulmonary GvHD, but it is not necessary to make the diagnosis. And we also don't do open biopsies because it is again associated with a certain risk, and it usually does not give you that much more information.
Okay. Okay, so if there are no more questions, actually, you will have a chance to ask directly to Saskia during the lunchtime. Thank you very much.
No, thank you.
Thank you very much. And now another reference in the field, José Luis Piñana, is going to talk about us about the infectious complications after transplantation. José Luis, welcome. es? ¿Cuál es? Aquí. Ahora espérate porque no estoy seguro yo de que estemos compartiendo la adecuada. No, no estoy seguro. Sí, no, ya la he compartido. Espera. Espera un momento. ¿Se ve bien online?
Hay que ponerlo en modo presentación, si no, no se ve bien.
Si no, no, si ya he ido a compartir pantalla. Compartir. Ah, vale, aquí está, sí, esta es. Y ahora ya sí. Okidoki. Gracias.
Thank you very much. I would like to thank Jose Antonio for inviting me to this great meeting, and congratulations regarding the 3,000 transplant procedures. I am José Luis Piñana from the Hospital Clínico Universitario Valencia, and during the next 20-25 minutes, I will try to summarize the most relevant aspects of infectious complications and management through the presentation of a clinical case. These are my disclosures, and this is a case that I will present you. Is a 29 years old male with a Hodgkin disease in second complete remission after 5 lines of therapy, including auto transplant and nivolumab before the allogeneic stem cell transplant. He has no medical issues before transplant except the decreased DLCO. The CMV status between donor and recipient show a high risk of CMV reactivation. The donor was positive for hepatitis B virus serology. The left ventricular ejection fraction was normal, and he was colonized by E. coli ESBL. He received an haploidentical family donor transplant from his father, conditioned with a reduced intensity. The GvHD prophylaxis was based on POSI and sirolimus and MMF. The antimicrobial prophylaxis that he received was acyclovir, letermovir, micafungin during the neutropenia, and then we switched to posaconazole. And then he received also entecavir because the donor was positive for hepatitis B virus. And of course, he was on the Bactrim until CD4 recovers. The numbers of CD34 were high, quite high. We can review the recommendations for prophylaxis in the setting of allogeneic stem cell transplant. Regarding quinolones prophylaxis, there are some controversies right now because the quinolones can alter the diversity of microbiota, and the low diversity of microbiota has been associated with an increased risk of GvHD. So some centers do not perform quinolones prophylaxis during neutropenia. Fluconazole is recommended for low-risk patients of mold infections. Also, micafungin could be an option. And in cases of high risk of mold infections, it is recommended to use posaconazole or voriconazole. Letermovir has been approved recently, so in this country we already do letermovir prophylaxis until day plus 100 in receptors positive. Septrin or Bactrim is recommended to make a prophylaxis against pneumocystis and also toxoplasmosis. Acyclovir is recommended until day 30 for HSV and until 1 year or withdrawal immunosuppression for zoster virus. And in our patients, we use entecavir for prophylaxis during 1 year, given that the donor was seropositive for hepatitis B virus. Well, the patient was conditioned. He received a stem cell transplant, stem cell infusion on day 0, and at day 1 he develops fever, skin rash, diarrhea, and a mild hepatitis. So we face to a clinical behavior that include fever, skin rash, diarrhea, hepatitis in the context of a neutropenia, a pre-identical transplant, and POSI. So the main differential diagnosis include infection causes and non-infectious causes. Among the infectious causes, there were the bacterial agents. Our patient was colonized by an E. coli ESBL. However, he has no prior history of fungal infection. And regarding viral agents, it was too early to think about a CMV reactivation or any other virus. Among the non-infectious causes, there is a cytokine storm. It is quite frequent in apple transplant procedure in the POSI. More than 50% could develop this kind of symptoms. And on the recognized syndrome is the alloreactive syndrome that mimic hyperacute graft versus disease. In this case, we have a high CD3 counts infusion. And the patient did not receive transplant at this time, so transfusion at this time. So blood transfusion reaction was not considered as a possibility in the differential diagnosis. And chemotherapy, radiotherapy were not related with this clinical feature. We performed the diagnostic workup among the infections, proves that we have blood, urine, stools, cultures that were negative. Also, fungal markers were also negative. The PCR for several more relevant viruses were also negative, and the chest X-ray was normal. Well, the epidemiology of multi-drug resistant bacteria is important to know. In our milieu, it's quite prevalent, the ESBL colonization in our patients. 20% has been estimated, and we should know that at least 30% could develop a bloodstream infection when they are colonized by this bacteria. Regarding multi-drug resistant bacteria with carbapenemase, is less prevalent, 5%, but still more than 10% could develop a bloodstream infection. So we should be aware of that. And when we decide to put a patient on an antibiotic, it is good to know this data. This is an important slide that I consider very useful in clinical practice. Science, we need to know what we are covering each time we use an antibiotic. Well, recently, the STIL-10 has reviewed the recommendation of empirical antibiotic therapy. And this slide summarizes the recommendation regarding patients that are colonized by multi-drug resistant bacteria. It was in a format of questions, of relevant questions. The first was if there is an increased risk of developing bloodstream infection in patients who are colonized. And the answer, according to the bibliography, is yes for gram-negative and also yes for gram-positive. So the next question is if there is any correlation between inappropriate antibiotic, empirical antibiotic therapy and mortality in those who has colonization with multi-drug resistant bacteria. The answer is yes for gram-negative, but not for vancomycin-resistant Enterococcus or gram-positive multi-drug resistance. It is possible to decolonize our patients before the procedure. There is a very limited data regarding the use of antibiotics, so it is not recommended to decolonize our patients with antibiotics. However, there is some data that shows evidence that transplant with fecal microbiota could lead to the decontamination of our patients. So it is also appropriate to use the novel anti-beta-lactamic agents to treat neutropenic patients with fever and colonized with multi-drug resistant bacteria. The data is limited, but with good results with ceftazidime, avibactam, ceftazolam, tazobactam, with the imipenem, relebactam. So in most of centers, we have these new antibiotics that could be very helpful in this situation. Just to remember that this is two ways of treating empirically our patients, the escalating and the de-escalating way of starting antibiotics. In our case, we choose the de-escalating way, since we know that our patient was colonized by an E. coli ESBL. And the recommendation in these cases is to start carbapenem monotherapy or a combination of anti-pseudomonal beta-lactam with an aminoglucosid or aquinolone. Our patients, we start meropenem in monotherapy, but we did the diagnosis of alloreactive syndromes, and we start antipyretics and 3 doses of hydrocortisone with resolution of the rash, the diarrhea, and the hepatitis. Well, our patient developed upper respiratory tract symptoms at day +3, and given that it was neutropenic, we start oral ribavirin. On day +17, he develops a severe transplant microangiopathy. 4 days later, he recovers. And on day 25, he developed respiratory failure. At this time, he had also fever, and he developed a breakthrough CMVD anemia requiring preventive therapy. So we perform a CT scan, and we observe a cotton wool infiltrate. That means an interstitial infiltrates. So among the differential diagnoses that we have in this case, at this situation, we have the Perrin-Graf respiratory syndrome, bacterial pneumonia, pulmonary edema due to heart failure, or diffuse alveolar hemorrhage, idiopathic pneumonia syndrome, or the parainfluenza virus progression to the lower respiratory tract. Just to review, as in the prior presentation, the pulmonary syndromes, they are classified among infectious and non-infectious. Among the non-infectious has been also already reviewed, and among infectious, there are several causes: bacterial, viral, and fungal infection. This is important to note that the time of presentation could vary, and sometimes both could often overlap. So what was our next step for respiratory failure diagnosis? We choose to make a cardiac Doppler ultrasound and cardiac markers. And we found that the left ventricular fraction ejection was 25%, along with high levels of proBNP. The diagnosis at this time was pulmonary edema due to heart failure in the context of POTS-I in a highly treated patient. We treat with diuretics, we reduce fluid intakes, and the hair function improved. However, even when we were able to reduce oxygen support, the patient still continue with oxygen requirement. So we perform again a CT scan, and at this time we found a ground glass infiltrate. We decided at this time, since the patient was already stable, to perform a bronchoalveolar lavage. It's just to remind that bronchoalveolar lavage, when it's performing in this kind of patients, it should include a wide a study of different microbiological agents, bacterial, fungal, and viral. We have already, in most of microbiologic laboratories, the multiplex PCR that includes a lot of pathogens that could be ruled out. So the question in this case is what was the differential diagnosis for our patient? We have CMV pneumonia, just sequelae of an improvement of pulmonary edema, or the progression of the parainfluenza virus, or diffuse alveolar hemorrhage. So we had the results at the following day of the bronchoalveolar lavage, and the only thing that we found was the human parainfluenza virus, and the patient showed a high risk immunodeficiency scoring index. So we can diagnose this patient of proven lower respiratory tract disease caused by parainfluenza virus. We continue with ribavirin until symptoms improvement on resolution. Just to remember that the certainty that we classify the degree of certainty of lower respiratory tract disease comes from the group of Seattle, according to the radiology results, or and the bronchoalveolar lavage result. It could be a possible, probable, or proven. This classification has an impact on prognostic, so we think it's useful to use in clinical practice, since the worst outcome is for proven lower respiratory tract infection. So, as you may know, there are several respiratory viruses circulating in our community in a seasonal pattern. In fact, we have another one that has been added in the last 5 years, the SARS-CoV-2, and it circulates also among the common seasonal respiratory virus. The incidence of respiratory virus infection in the first 100 days is pretty high. More than 30% could develop a respiratory virus infection. This is a prospective study from Seattle in a weekly based screening that they found more than 30% of cases with RSV infection, with respiratory virus infection. And what among the respiratory viruses are those who progress the most to the lower respiratory tract? This study has analyzed this issue, and they found that RSV and human metapneumovirus are both the most important virus progressing to the lower respiratory tract, followed by parainfluenza. It's important when we have a respiratory virus to know the risk factors. The most relevant risk factors, the most relevant risk factor is lymphopenia. Lymphopenia has been validated in several respiratory viruses, but there are also others like mismatched cells between donor and recipients, or related donors, or early infection after transplant, and neutropenia. The lymphocyte count has an inverse correlation with the risk of progression to the lower respiratory tract. The lower lymphocyte count, the higher risk of progression to the lower respiratory tract. Important to be aware that co-infections are common, 13 to 15%. So we should think about it. And when they develop, that can be severe. In fact, bacteria with respiratory virus co-infection show the worst results in terms of survival. Regarding antivirals and vaccines, we have influenza, RSV, and SARS-CoV-2. Both have vaccines, both have quite approved antivirals. Um, the other virus has no established treatment, but there are some data that shows some efficacy of ribavirin in parainfluenza virus, and the evidence is lower for human metapneumovirus. When we have a patient with lower respiratory tract infections with a respiratory virus, it is important to perform a CT scan to assess risk factors, to rule out co-infections, to perform, if possible, and whenever possible, a bronchoalveolar lavage, to start antiviral as soon as possible, if available, and don't forget to perform pulmonary function tests after recovery, since the respiratory virus can trigger bronchiolitis obliterans syndrome. Well, our patient was discharged successfully, and we start immunosuppression withdrawal at the time, 3 months after transplant. And at this time, we observe an increase liver enzymes suggesting an hepatitis. So the differential diagnosis of hepatitis at this time point, 3 months after allogeneic stem cell transplant, include chronic graft-versus host disease, very rare, but it is possible, a late sinusoidal obstruction syndrome, drug toxicity, iron overload, or viral hepatitis. So what we do to diagnose this case, we choose to perform a Doppler ultrasounds with elastography and a PCR of most of hepatotropic viruses. In fact, our patient in the physical examination showed a lichen-like lesions in the mouth. He has also a dry syndrome and a poikilodermia. The ultrasound of the liver was normal, so the diagnosis at this time was chronic graft-versus host disease, de novo, but mild, except for transaminitis. So we keep this patient on topic treatment without systemic immunosuppression until have the results of the hepatotropic virus. And 1 week later, we found a positivity for hepatitis E virus by PCR. It is important to remember that several viruses can cause hepatitis in our patients, not only the viral hepatitis A to E, but also adenovirus, CMV, Epstein-Barr, herpes simplex, varicella zoster. So we should keep in mind that in the differential diagnosis. Just to remember the physiopathology of hepatitis in the context of an hepatotropic virus. It has been divided in three phases: the viral phase, the immune reconstitution phase, and the resolution phase. The transaminitis, that means the hepatocyte damage is not caused by the virus itself, but by the lymphocyte that is able to recognize infected cells and attacking these cells. They produce uh, the death of hepatocytes. So, in this context, if we introduce immunosuppression like corticosteroids, it is likely that the liver function improve, but that not means that it's a GvHD. So you should keep in mind that with immunosuppression, even in a context of an infection, the liver function can improve. There are several guidelines that suggest to manage and to make a screening of hepatotropic virus in these patients. It is recommended to screen for hepatitis B, C, A before transplant, mainly through PCR. Regarding the treatments of hepatitis C, we are lucky since we have the direct antivirals that are quite effective. Um, we recommend to consult with a GI specialist to treat these patients. As these kind of treatments are are quite long. For hepatitis B virus, two new antivirals, tenofovir and cecavir, are quite effective. And for hepatitis E virus, the recommendation suggests the use of ribavirin uh, in this context. So we use ribavirin in this patient without systemic immunotherapy, immunosuppression, and the liver improve. So and the hepatitis E virus was negative in the follow-up. And 9 months after transplant, the patient was doing well with mild GvHD, not requiring therapy, but he complained from muscle weakness in right hand and left foot. At this time, we perform an MRI, and we observed several demyelinating lesions in both hemispheres. So we face to an encephalitis. This is the most important cause of viral encephalitis, fungal encephalitis, and bacterial. In red, the most common encephalitis is incidence is less than 2% in transplant patients, and among the most common virus are the GC virus, the herpes 6 virus, herpes simplex, enterovirus 71, and more rarely CMV and Epstein-Barr. So in this case, we perform a PCR of the spinal fluid, and we found GCV virus with a PCR of CD38. So we make the diagnosis of progressive multifocal leukoencephalopathy in this patient. The clinical was subacute, progressive with motor deficits. This kind of infections has a very poor prognosis with mortalities higher than 80%. So very few limited options for this patient. We start this patient on cidofovir, mefloquine, gamma globulins. The PCR persists positive during 3 consecutive determination, and we decided to perform a cell therapy with CD45 depletion of lymphocyte from the donor with several infusion in order to provide some immunity from the donor that to the patients, as our patient was with 100 CD4 9 months after the allogeneic stem cell transplant. With this strategy, GC virus became negative in the cerebral fluid, and lesions improved. Some of them remain stable. The clinical was also improved with very few sequelae and disabilities. So we think that we have cured this patient, and 4 years later, the patient is in complete remission with any other symptoms of encephalitis and with a good quality of life. Just remember that the infectious cell therapy is a reality. There are several options. In the early period, we only have donor lymphocyte infusion, and it was very, very tricky to perform because the high risk of graft-versus-host disease. In most centers, they can do CD45 RAB plus depletion, infusing memory T cells to the patients that needs with a lower risk of graft-versus-host disease. And there are also other more difficult to have cell therapy for CMV or Epstein-Barr that could be obtained from direct T cell selection through Clinimax or Prodigy or ex vivo expansions. And also there are some research on CAR T cells against some infectious agents. So as a conclusion, infections ranked as the second or third leading cause of mortality among allogeneic stem cell transplant recipients. Infectious disease in these populations are diverse and often opportunistic, so reflecting the unique vulnerability pattern of our patients. Managing infectious complications constitutes a significant aspect of our clinical practice, so we need continuous learning and update knowledge in this field. Thank you very much for your attention. I will be glad to answer your questions.
Thank you, José Luis. It's such a case to learn a lot about infectious complications. It's time for questions.
Thank you, José Luis, for this comprehensive review of infections after the transplant, based just in one case, which maybe remind us the old concept that post-transplant cyclophosphamide is associated with opportunistic and very especially viral infections, because these patients suffer from several viral infections. But I want to come back to maybe the first decision you took on this patient, that was to start empiric antibiotic therapy, which is a lot of sense in that case. And you selected to use the de-escalating approach. And based on the colonization for a resistant E. coli, also a lot of sense. And I want to ask you, what is your approach regarding when to use the escalating or de-escalating approach in this so frequent decision we have to make that start antibiotic empirical therapy? And second, if you have any policy regarding when to stop or when to de-escalate in the case you start escalating the antibiotic therapy, especially regarding the well-known dysbiosis problem that related with antibiotics. Thank you.
Okay. Regarding your first question, when we use escalating or de-escalating, is we follow the guidelines of the SCL recommendation. And when a patient is not colonized by a multidrug-resistant bacteria, we prefer to use the escalating strategy. So we start with an anti-pseudomonal antibiotic, and in case of a breakthrough bacteremia, we escalate, or a persistent or a septic shock, we escalate. In case where we have documented previously multi-drug resistant bacteria, uh, not only in colonization, but also in previous prior episodes of multi-drug resistant bacteremia in the same patient, we prefer to use the de-escalation covering a broad spectrum of bacterial agents. Regarding the second question, how long we use antibiotics, this is a quite controversial question that we have talked several times with you. And one of the questions that we have is when we de-escalate from a broad spectrum antibiotic to a prophylactic quinolone, in our experience, most of patients restart fever. And when they restart fever, we are somewhat directed to another antibiotic, not the previous one that we use, but another family of antibiotics. That means that you are exposing your patient to two different antibiotics, and this is probably has an impact on the microbiota diversity compared to use only one. So when a patient is stable, the PCR became negative, inflammatory markers are negative. Sometimes we stop the antibiotic, we come back to the prophylaxis with quinolone. But in patients that remain afebrile, but the inflammatory markers are still elevated, we prefer to keep the same antibiotic that we use in the first episode until neutrophil recovery, or until we were sure that there is not a bacterial infection in this patient. So it depends on the circumstance of each patient. You can use one to another policy.
More questions. Jose Luis, you are using a prophylactic approach, using quinolones, if I'm not wrong.
At our center, no, we don't use, but as you have seen in the clinical case, uh, we used to see fevers the day before of a stem cell infusion. So in practice, if we use quinolones, we probably use for one day, because we already start a broad spectrum antibiotic, given that the patient is neutropenic, he develops fever, even when we know that this fever could be alloreactive or a cytokine storm fever. But the patient is neutropenic, we need to cover. So it is, even when we don't use quinolone prophylaxis, uh, it is hard to see if to don't use this strategy has improved outcome compared to the use it, because the alloreactive fever make us to start early in several cases broader spectrum antibiotics. So this is the problem that we have. Even when we abandon the prophylaxis, uh, you know, finally the patient got a broader spectrum antibiotic early.
Mhm. So regarding the prophylaxis that you mentioned in the first slide, there's a lot of controversy still about using or not antibiotics. In our institutions, we do not, but I mean, there are still many centers which is the standard approach. Could you discuss on the pros and cons of using or not this kind of...
There is no evidence what to do. The only evidence is an indirect evidence. This came from microbiota studies. that suggests that a low diversity of microbiota is associated with worse outcome in allogeneic cells on transplant recipient, and that's why there is an indirect suggestion of not performing quinolones prophylaxis. But it depends on the centers. We have a lot of experience with quinolone prophylaxis, and we know that quinolone prophylaxis reduce gram-negative bacteremia in neutropenic patients. So, it depends on the choice of each one. I cannot recommend with a high degree of evidence what to do. It depends also on case by case. For example, if you have a patient colonized by a multi-drug resistant bacteria, probably it doesn't make sense to do a quinolone prophylaxis if the bacteria is resistant to quinolones. But in patients who are not colonized, for example, it could be useful for the patient. We need more data on microbiota to know if it's a cause or a consequence of the procedure.
So regarding the viral infections, the respiratory viral infections, there is no doubt about the use of antiviral treatments when we already find an infection of the lower respiratory tract. But regarding the patients who do only have infection in the upper, still there is a gray area on when to treat and when not to treat. What would be your recommendation? Which patient we should still maintain antiviral treatment, and in which one we can just be confident enough and not to give any treatment?
Yeah. It's a very important question, I think, in the period that we are living. We used to treat all respiratory virus that has approved treatment, such as influenza, irrespective of the risk factors. If you have a patient with an influenza virus, you have the oseltamivir, use it, even when it is limited to the upper respiratory tract. Also for SARS-CoV-2. In other viruses that the evidence of antiviral effect is not so strong, we prefer to treat those at high risk of progression to the lower. And there are several risk factors that we already know. And one important score is the immunodeficiency scoring index that has been validated in several respiratory viruses, RSV, parainfluenza, coronavirus, the common seasonal coronavirus, that can be used to decide to use an antiviral that is not approved. If the patient is at high risk of developing lower respiratory tract, it could be treated with ribavirin in the case of RSV or in the case of parainfluenza virus.
Mm-hmm. And then regarding the prophylaxis of other infections or reactivations such as varicella zoster, and now that we have the vaccine, unfortunately, it's not clear at all when we should stop acyclovir. And the current recommendations actually goes up to 2 years, but there is a lot of toxicity regarding the drug. Renal toxicity, but also financial toxicity for the patient. So what do we do regarding acyclovir, particularly in patients who are receiving the vaccination?
Yeah, this is again a very relevant question. And what we do at our center is to start vaccination before to stop acyclovir. We give two doses, and 2 months later, after the second dose, if the patient is candidate to stop acyclovir, we stop it. You have conditions that in the absence of vaccination, you still continue with acyclovir. I would recommend to continue with acyclovir. Even when it is toxic, it could be expensive, it is very effective. And there are some reports that when stopping acyclovir in patients that receive a full vaccination, there are several cases of varicella zoster reactivation. But the evidence suggests that the most important response is after the second month of the second dose of the zoster vaccine. So it could be the best moment to stop the acyclovir 2 months later after the second dose. If you decide that that your patient doesn't require anymore acyclovir, it could be the moment. But vaccinate the patient before to stop acyclovir, I think is the main message that we can make.
This is an important and practical information. So if there are no more questions, Jose Luis, thank you very much.
Thank you.
I think you can see the screen, those who are online. We are going to face another complication after transplantation that we've not devoted a lot of time to it, but it's getting more and more importance after transplantation, and it is microangiopathy. As long as our knowledge is increasing about this complication, we really realize that the incidence is not as low as we thought a few years ago. And basically, it is obvious to say that we have so many endothelial cells all around the body, and that these are actually the main cells, or the first one, which are interacting with the T lymphocytes from the donors. So the first reason for being just a target of this allogeneic recognition, but also endothelial cells are targeted by the conditioning regimen and have damages which affect their functionality, and at the end of the day are responsible for the development of endothelial damage syndromes, which represent a variety of diseases. In fact, from a physiopathological point of view, as you can see in this slide, endothelial cells are playing a role. It is obvious that they do in the development of GvHD, since, as I mentioned, they represent actually the first cells which are interacting with the T cells from the donor, and they also actually are the ones leading these cells to go to the inflammatory places or not, based on the expression of selectins, adenosines, or other molecules. So with this idea in mind, I want to share with you this case, which is only partially based on a patient that we have been recently attending in our bone marrow transplant unit. He is a 59-year-old male diagnosed with a high-risk acute myeloid leukemia. He received an allogeneic stem cell transplantation from an 8 out of 8 match unrelated donor after reduced intensity conditioning with tiotepa, fludarabine, and busulfan. GvHD prophylaxis consisted on post-transplant cyclophosphamide plus tacrolimus and mofetyl mycophenolate. On day plus 17 after transplantation, the patient was febrile and received treatment with wide-spectrum antibiotics. By that time, proteinuria, which is actually monitored in our unit once or twice per week, was negative, and the blood pressure was normal. And this is the evolution of the hemoglobin levels and the platelet counts levels. Hemoglobin was in the range of 8, but it was due to red blood cell transfusions, and the same for the platelets. They were in the range of 20,000 because of platelet transfusions. By contrast, the granulocyte counts were increasing, and by day 17, actually, it was above 1,000. On day 21 after transplantation, the patient remained febrile under treatment with wide-spectrum antibiotics, meropenem, plus acyclovir and posaconazole, and started complaining with abdominal pain and bloody diarrhea, around 20 stools per day. The stool cultures were negative, so that a colonoscopy was indicated. And by that day, the proteinuria became positive with a 1.5 milligrams gram of urine creatinine proteins ratio. The LDH was increasing, as you can see on the left part of the slide, above 300. Creatinine was also slowly increasing, and we did detect schistocytes in the blood smear. So according to the classic and different guidelines and criteria for the diagnosis of microangiopathy, actually our patient did fulfill criteria for making the diagnosis of transplant-associated thrombotic microangiopathy, since he had thrombopenia, he had anemia, he had biological markers of hemolysis, and also had proteinuria. And if we use the more recent harmonizing definitions for the diagnosis of TMA, our patient had anemia, defined as the failure to achieve transfusions independence of red blood cells despite evidence of neutrophil engraftment, which was the case, also thrombocytopenia, elevated LDH, schistocytes, and proteinuria. Therefore, the diagnosis of TMA was performed, and we look for the colonoscopy results. The presence of diarrhea at that time point makes us to perform the differential diagnosis between TMA in the gut versus gastrointestinal graft versus host disease. And unfortunately, this differential diagnosis is not only difficult, but frequently both frequently overlaps and have these clinical signs such as severe abdominal pain, GI bleeding, which would be more common or more typical in the TMA, radiologic signs, which are also common, such as signs of ileus or thick mucosal wall. They can appear in both diseases. And in the GI endoscopy, we can find mucosal erosions and hemorrhages, which would be more typical but not definitive diagnosis of post-transplant microangiopathy. Unfortunately, the histologic differential diagnosis is also rather complex because both entities share common features. It is more typical but could appear in both of TMA, the presence of creep loss, mucosal infarcts, mucosal hemorrhages, and red cell extravasation, and mucoid subintimal thickening. And on the contrary, they can also appear in both entities, although they are more typical of GvHD, the presence of severe bilious atrophy and creep degeneration, and mucosal ulcerations, patchy or diffuse. While it is far more typical of TMA and are not so commonly seen in GvHD, the presence of schistocytes and fibrinoid debris in the vessels, intravascular thrombus formation, and endothelial cell swelling and separation. So we should look very carefully for these signs in the histological examination. While it is much more typical and common in GvHD, the presence of infiltrating immune cells close to apoptotic cells. These are satellite cell necrosis. These are the features. You can see this balloonization or degeneration of the endothelial cells in the walls and the presence of thrombi inside inside the vessels. Unfortunately, we did not have these signs and symptoms in the first biopsy that we performed in our patients, so we did not have a definitive diagnosis of histologic TMA or GvHD in our patient, at least at that time point. But anyway, we have the suspicious of having also GI involvement with TMA, and it is actually one of the target organs that can be involved in this disease, the GI, in which the characteristic signs or symptoms are or include GI bleeding and intestinal stridors requiring medical or surgical interventions. Because of that, so we could not rule out or confirm the diagnosis of TMA or GvHD. On day 21, we started this patient with steroids at 1 milligram per kilo Q12 hours, but we also tapered the dose of tacrolimus in order to avoid the risk of worsening microangiopathy and maintained MMF every 12 hours. Very few days later, on day 23, the patient had confusion and decreased alert, and a CAT scan was performed and an MRI showing images with areas of hypodensity in the subcortical region, both parietal regions and in the left temporo-occipital region, as well as in the posterior region of both coronae radiata. According to the radiologist, the patient had signs which suggested the diagnosis of posterior reversible encephalopathy. And with this finding, we stopped tacrolimus, started on ruxolitinib, and we also started on eculizumab. By that time, therefore, we had involvement of CNS, which is defined as the presence of these symptoms, confusion, altered mental status, which our patient had, together with seizures, with or without imaging evidence of PRES, which our patient had. And also we had a suspicious involvement of GI, which was confirmed days later with a re-examination of the biopsy that was performed, indicating to the pathologists that they should focus on the damage of the endothelial cells in the vessels of the gut. This was the evolution of the different parameters in peripheral blood. Hemoglobin levels were remaining around 8, but still requiring red blood cells transfusions. Platelet still remain low and also requiring platelet transfusions to maintain levels in the range of above 20,000. Granulocytes keep on rising. LDH also keep on rising together with creatinine, and the levels of schistocytes initially increase, and subsequently they remain stable in the range of 3 per smear. Among other biological parameters, total bilirubin was increased, and also we observed an increase in the levels of transaminases. Now, a few days later, the patient started with additional problems. He started gaining weight. He had hypoxemia, remains febrile. Diarrhea was improving, 5 stools per day, but he required oxygen support to maintain a saturation of oxygen within the normal range. An echo Doppler ruled out abnormalities suggesting veno-occlusive disease. All the cultures were negative, and a CT scan was performed showing these images. According to the radiologic information, the radiologist indicated the presence of an extensive bilateral alveolar consolidations, and they suggested the differential diagnosis between an idiopathic pneumonia syndrome, diffuse alveolar damage, and or bilateral bronchopneumonia. There was also some mild right and minimal left pleural effusion. With these findings, we asked for a bronchoscopy, which was performed, and the cultures were negative. Only very minor area of bleeding were observed, but biopsy was not performed at that time. So now in these patients, we are facing this differential diagnosis. This slide has been already shown a couple of times during this meeting. A lot of different complications in the lung which might appear at this time point, both infections and non-infections episodes, but considering the diagnosis of TMA in this patient, actually we focus on non-infectious complications, and particularly we focused on those complications which might appear in the lung in the context of diseases related to endothelial damage. Particularly, as you can see, we can find diffuse alveolar hemorrhage, but also idiopathic pneumonia syndrome, which actually were the both disorders that the radiologist pointed out according to the CAT scan findings. So just a brief reminder about what we could typically see in a diffuse alveolar hemorrhage. These are the typical images we should find. From a clinical point of view, the signs would be quite similar to the ones that our patient had. In the CAT scan, we should observe these patchy multifocal or diffuse ground glass opacities with superimposed septal thickening, creating a crazy paving pattern. In the bronchoscopy, we should see an active bleeding, and that would be actually the most important sign that we could find and could orient the diagnosis. And also, this would be the most typical pattern of an idiopathic pneumonia syndrome. Again, similar clinical symptomatology with hypoxemia, and in the images, we should observe these bilateral patchy areas of consolidation and ground glass attenuation. The final diagnosis of involvement of lungs with a microangiopathy should be performed or would require to have an histological examination. And in this case, we should observe changes in the pulmonary arterioles with denuded and injured endothelium, microthrombos, and schistocytes extravasation in the lungs. So we asked for a biopsy that we did not have at that time, but irrespective of that, now we received the confirmation that the histological examination in the gut actually displayed features, histological features characteristic of microangiopathy. And therefore, we have a patient who has GI involvement by microangiopathy characterized by the bloody diarrhea that our patient had, central nervous system characterized by this confusion and altered mental status, depressed syndrome, and now we also have pulmonary involvement in our patient. So this is an all-in-one case of microangiopathy, which is a real case patient. And on day 38, he is receiving eculizumab 3 doses plus high-dose steroids plus ruxolitinib. He remains febrile. Diarrhea has improved 4 stools per day. The requirements of oxygen right now are lowering, but still the platelet count remained low, as well as the hemoglobin level. The LDH level remains high. Although lowering, the creatinine has decreased to 1.5. Schistocytes are still identified in the blood smear. So this is a still open case, and in this case, we are actually wondering, we are asking about the following issues or questions. Should we have the lung biopsy or not in order to make a final diagnosis? Should we use some anti-TNF drug based on the data of the potential efficacy of these drugs in the interstitial pneumonia syndrome? Should we somehow modify the immunosuppressive drugs? And actually, these are the questions that the audience does not have for me, but I have for the audience. So we are open to suggestions. What do you think about what should be next in this patient? Can you confirm that it is?
No, I think. I will suggest another question, which is the dose of eculizumab, because the response of the microangiopathy has been related with the dose of eculizumab. So in order to adapt the dose, it's necessary to have available to determine the levels of the drug in the blood, which is, I know, it's not easily available in our center, but just to complicate a little bit more the case, the dose of eculizumab should be another consideration.
That is a good point. In case that this patient is not responding, we should not only think about looking for another diagnosis or treatment, but to make sure that we are actually providing the right dose and to reach the appropriate levels, which is not always easy in with this drug. Good point. So I'm looking for your suggestions. No suggestions from the audience. We're not lucky today. Would you? How would you envision the need for a lung biopsy, Saskia?
That word? Yeah.
Now,
Well, I think you're pretty sure here that you are dealing with TMA because the combination of you already had the central nervous system, you already had the GI bleeding. Not sure how well the patient is at that moment regarding oxygen requirement, etc. So it is a risk, of course, to do a lung biopsy. And if you have ruled out active infection with the bronchoscopy, bronchoalveolar lavage fluid, I think I would not do the lung biopsy.
mm-hmm. Okay, but let me argue against that, and is the fact that if we make the diagnosis of interstitial pneumonia, then we could change the treatment and add some anti-TNF drug. But that would only be possible if we have such a diagnosis. Or would you directly go for that treatment in addition to the ones that the patient is receiving, which might be another option? What do you think?
Yeah, challenging question.
Jose Luis also wants to provide his opinion. I see your face.
Well, in this case, I will perform again a bronchoalveolar lavage to be sure that there is no other infection because the patient is already very immunosuppressed. But I think it is important to have the diagnosis before to decide to immunosuppress more the patient. So I probably will choose a lung biopsy before to start empirically more immunosuppressive agents.
Actually, that's what we did. We went for a second lavage, which confirmed that there are no infection, and we are waiting for the results of the histological examination that we do not have so far. And the comment of Jose Luis is important because the anti-TNF drugs have been related with a very high incidence of fungal infections after treatment. So that's a concern. But on the other hand, the results with this treatment is basically the best ones, even though they are poor, in patients with this complication, interstitial pneumonia syndrome, isn't it? Okay. So as you can see, this is as difficult as it can be. And I think that this is the perfect moment to finish this session because actually this is a meet the expert in transplant complications, which are something like this. Many differential diagnoses, many complicated diseases, which actually may interact and appear in the same patient at the same time. But in any case, we hope that you have enjoyed, that you have learned. Basically, I did a lot with the experts that have been with us these couple of days. Both of you being here or online, I hope you have been able to pick up practical information, but also important novel areas of knowledge. Our aim was to focus on these complications from a clinical, but also from a biological point of view. And I would like to finish actually inviting you to another activity. Actually, it was going to be impossible to do it, but since there was a drop in one of the speakers, actually, this is an opportunity for you to join us to the last social event. As you know, in this year, during the Meet the Expert, we are also celebrating our 3,000 transplants, and there has been a lot of activities in the hospital. The last one is the one I invite you to participate right now, not for those who are online, but those who are here, and it's at 1 o'clock. There will be a class of yoga just in front of the main entrance of the hospital, And there will be a lot of patients and patients associations participating on it. They are actually collecting also some funds for making a common proposal for all the associations of patients. So I think it's going to be very nice for all of us if we join them. And after that, at 2 o'clock, the lunch will be served as yesterday in the yard, which is in the center of the hospital, where we had it yesterday. So to all of you, particularly to the speakers, thank you very much for sharing with us these couple of days. And we finished this Meet the Expert, and we look forward to meeting you here next year. Thank you very much.